giving a little background about who I am and my background, and then talk through generally sleep health, healthy sleep habits, review insomnia, circadian rhythm disorders, primarily delayed sleep phase, because that is what is most common in adolescence. And then we can talk through case examples and questions. And please, 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 if you have any questions along the way, feel free to interrupt and ask questions. I'm happy to talk and make it conversational. So just a little bit about me. I actually got my PhD in clinical psychology right here at Northwestern. Then I did one of my clinical externships at Children's National in Washington, D.C., and that is where I worked with Danny Lewin and Judy Owens in the Pediatric Sleep Center and fell in love with sleep. I went on to do my clinical internship at UNC Children's Hospital, where I really focused broadly on what we refer to as pediatric psychology. So working with youth with acute and chronic illness and figuring out how to support them. I worked for 3 years at Advocate Children's Hospital, where I both did sort of broad child and adolescent psychology work, as well as working with their sleep medicine program. And I am thrilled to kind of come full circle and be back at Lurie, where I'm now working as a full-time pediatric sleep psychologist. So I wanted to give a little background on what does a sleep psychologist or a behavioral sleep medicine specialist actually do. So the main things that I will see in my practice are kids who have a lot of bedtime resistance, curtain calls, fighting going to sleep, demanding that a parent be there as they're falling asleep, and what we refer to as behavioral insomnia. And what that often means is that kids who are falling asleep with a parent present or milk present and wake up in the middle of the night and need that same presence to be able to resume sleep. And so we work a lot on how to maybe change that bedtime routine to help them fall asleep more independently if that's what the family desires. I also see a lot of kids with insomnia. We will talk about that today, but it's definitely a growing concern amidst this COVID pandemic. I work with kids who are getting used to CPAP or BiPAP equipment. So when they have sleep apnea, I help them with just getting used to slowly using that equipment and getting comfortable with it. I see kids with circadian rhythm disorders, and what that means is just that their timing of the sleep is off. Most typically what we see is our adolescents who are going to bed much later than is great for being able to get up early and go to school. We do some work with kids who have narcolepsy or some other form of hypersomnia where they're very sleepy and sleeping a lot during the day, just trying to help them with building capacity and scheduling throughout the day. And then often I work closely with our sleep physician team with kids who have autism and other complex neurodevelopmental conditions, trying to figure out how to align closely just with their developmental needs to meet their sleep goals. So many factors, as you know, that impact adolescent sleep. I share this slide just because certainly there are a lot of different perspectives on what is healthy sleep, and I think a lot of it may be defined both by family preferences and cultural preferences, and as long as families are happy and the kids are getting adequate sleep, I think that that's important too, to align with family goals. So I share this slide. Obviously, you guys know that sleep is complex, multifactorial, but I thought it was just a helpful kind of reminder that, you know, sleep is influenced by family health, family preferences, health. You know, kids who have eczema and other skin conditions, sometimes sleep can be impacted. Sometimes it's, you know, we wish it was always as simple as figuring out, oh, they have low iron and that might be influencing restlessness, but oftentimes it's quite complex, and figuring out what are some of the driving factors impacting sleep can be helpful then to figure out how to treat it. So a little background on sleep health. What are we talking about when we say sleep health, right? So we're talking about duration, how long a child is sleeping. And there is obviously, the AAP kind of defines that there are ranges for each age, but we want to figure out, are kids getting enough sleep? And you certainly would know that based on things like daytime behavior and functioning. The timing of sleep is something we'll talk about today, especially in adolescence. Oftentimes there's a preference for going to bed later, which is largely impacted by early school start times. Consistency of sleep is also a major challenge in adolescence, where adolescents will basically, travel to California every weekend and then come back. And that throws off our circadian rhythm, our natural sleep clock. Continuity of sleep. So are kids sleeping through the night? Are they waking up in the middle of the night? What is the environment? We know that, loud noise or a lot of interruptions can make a big difference in sleep. And then I focus a lot, obviously, on what's happening in the room, what are their behaviors around sleep, and how does that impact all of these aspects of their sleep health. And I'm sure, as you all know, that insufficient and poor quality of sleep has physical and mental health consequences. One of the challenges I think that we face is that adolescents might not see those long-term consequences. They are very present-oriented. And so sometimes we can get buy-in by just thinking through how it's impacting their daytime behaviors if they're getting sufficient sleep. Their attention is poor, their mood may be changing, and trying to figure out how to help them to see that and to see a change. Okay, so I share this. I think it's important to think through what sort of the scene looked like prior to the pandemic and how things changed in the pandemic, because we actually have seen a dramatic rise in the number of referrals that we're getting and how severely sleep has been impacted as a result of COVID-19. So sadly, though, even prior to the pandemic, research suggested that about 58% of middle schoolers and 73% of high schoolers were not getting enough sleep, which was impacted a lot in a large part by use of television and electronics. Watching TV at bedtime has been shown to reduce total sleep time by at least 30 minutes. And I think it's interesting or perhaps scary to think through that a lot of this research was done prior to, more handheld electronic devices and just readily available electronic devices, which actually have been shown to impact sleep even more so than television. So when we're thinking about just the current climate that we're in with COVID-19, one of the major things that we're seeing in general in our psychology department, our psychiatry department, is just the huge rise in anxiety and depression. And there was actually a recent meta-analysis looking at over 80,000 children. And they actually saw that the rates of anxiety and depression have almost doubled. So, and overall, it looks like rates of depression were around 25% of adolescents were reporting some clinically significant level, and 20% of kids were reporting anxiety. So these rates are really, really high in the context of things like social isolation, changes in their access to just changes in their daily routine for a long portion of time. They were doing more remote learning where not only did they have more readily available technology, but they also perhaps were missing out on some of that social engagement, and then re-engaging has been very hard. But just the lack of physical activity, lack of daily activity, lack of sort of direct sunlight during the day that can largely influence our circadian rhythm can make a big, big difference. I can see that there's something in the chat, but I don't want to mess up the share screen. So if anyone wants to interject, please feel free.
No worries. We'll have them type up the questions and we'll ask afterwards, or raise your hand
Perfect.
afterwards.
Okay, perfect. So I want to talk about what is insomnia. You guys probably all have a basic sense of insomnia, but what we're looking at is one of three things. Do they have a lot of difficulty initiating or falling asleep? Are they waking up in the middle of the night, or do they have early morning awakenings with difficulty resuming sleep? And these, in theory, are supposed to clinically impair social work, educational functioning, and persist for at least 3 months. Thankfully, we work in a practice where we are able to catch things early. So please, 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 if you're seeing some of these signs, don't wait for those 3 months. Please reach out or intervene early. So when I see kids for an initial insomnia consult, some of the things that I'm thinking about and that I imagine you guys are already sharing is just thinking through, healthy sleep hygiene. What are some of the factors that may be impacting kids' sleep? Interestingly, obviously having a normal, consistent bedtime is important, but we also want it to be developmentally appropriate. I actually saw a family who parents were so worried about kid getting enough sleep that they were putting an adolescent to bed around 8 p.m. and mom was so worried she wasn't sleeping enough that she made her sleep in bed with her and was checking to make sure she was sleeping. And then trying to catch her if she was faking sleep because the kid was so worried that mom would be upset she was pretending to sleep. All of this pressure and stress and putting her to bed too early actually was a major cause of sleep difficulties. Consistency, again, that weekend, holiday, school breaks can largely impact the ability to stay on a consistent sleep-wake schedule. We see a decent number of kids get into sort of that negative cycle where they're napping during the day and then sleeping less at night. I really talk with families about coffee, tea, soda, even chocolate. Oftentimes families kind of aren't aware of like tea and the impact on wakefulness. We can talk through screen time at length. I think that it's an ever-changing climate, and some of it is coming up with a realistic goal for families, like what would actually work with them, because I think sometimes when we just say no screen time in the 2 hours before bed, families may dismiss us like, my goodness, homework, they have to do screen time. So talking with families about ways to minimize light exposure in the evening and to have a clear transition to bedtime. And again, I think that this is one that parents have a really hard time with, but they see their kids sleep deprived during the week. And so they then want them to sleep in on weekends and allow that. And that unfortunately just exacerbates this cycle. So trying to have kids have a consistent wake time every day, regardless of how long it took them to fall asleep. So the sort of first line treatment for insomnia, it's what's referred to as CBT for insomnia or cognitive behavioral therapy. You've probably heard of that in the context of anxiety or depression treatment. A lot of it is similar in the sense that we are trying to figure out from a cognitive perspective, what are their thoughts about sleep? Oftentimes by the time families come to see us, kids are really worried about their ability to fall asleep and stay asleep. And that unfortunately, again, continues this vicious cycle. So sometimes just helping to take some of the pressure off, again, both from, I think in a pediatric world, oftentimes some of that pressure inadvertently comes from parents, like they're not getting enough sleep. Taking a step back, focusing on, they've been functioning in this lack of sleep or whatever it may be for a long time. So let's take a step back and change some of those habits without as much pressure to fall asleep at a specific time and get a specific number of hours of sleep. We focus a lot on what we refer to as stimulus control. So And this again has to do with, you know, the traditional classical conditioning model. What happens is that when our bed becomes associated with wakefulness, frustration, difficulty falling asleep, video games, stress, whatever it may be that kids are doing in bed, it of course translates into more difficulty falling asleep than staying asleep. And so our goal is making bed for sleep only, or sleep and very, very sleepy and relaxed. And so what we're talking about is getting in bed when very sleepy. I sometimes will say when your eyes are closing and after the established bedtime. So we want to make consistent that their schedule is consistent and that they're really sleepy with when they're getting in bed, and if they can't sleep, climbing out of bed. So basically what happens is that at the beginning, because adolescents with insomnia associate their bed with stress or difficulty falling asleep, even if they're really sleepy, when they get in bed, it sometimes is hard to fall asleep. So the goal is, you know, especially maybe that first week when we're making a lot of changes to their schedule, what might happen is they climb in bed, they immediately feel alert, and then they get out of bed again. And that can be really challenging. So I think the goal is, hey, look, you haven't slept that well for a long time. We're probably not changing your total hours of sleep you're getting. It's just that we're not going to be doing those wakeful hours in bed anymore. And within likely a week, if you really, really do this, you're going to see major changes in your ability to fall asleep at bedtime. One of the things that I really work on with families is trying to figure out in their specific home environment, is there a different place in the bedroom where they can do their kind of relaxation, hangout time before bed, or if they're awake? Sometimes it's as simple as just like throwing some cushions on the floor and some pillows and blankets, but making it comfy so that they are motivated to get out of bed. So the other thing that families with kids sometimes are resistant to is the idea of sleep restriction. This is a major component of the CBTI protocol in adults. Basically, the idea is that with insomnia, we spend a large amount of time in bed relative to the amount of time that we're actually asleep. And so the goal is, you know, if we were able to track sleep for a couple of weeks, we would figure out how many total hours is the child sleeping most nights. So let's say it's 7 or 7.5 hours. We can add on like a half hour, but that sleep window, so maybe say like, you know, 11 to 7, you don't want them in bed otherwise. So no matter how tired you are, limiting your sleep to that window over time in conjunction with only being in bed for sleep, what happens is sleep starts to consolidate. So we start to sleep during that window because we're limited to that window. And gradually, once kids are sleeping well during that period of time, we can expand it slowly. So we talked a little bit about cognitive restructuring, changing the way we're thinking about sleep. I spend a lot of time thinking through anxiety, as we discussed, mood, and we do a lot of building in relaxation as part of the bedtime routine. And then figuring out for each kid, you know, I certainly get a fair share of, I don't like meditation, I don't like relaxation. For some kids, you know, we practice and they realize that they actually do like it. But for other families, it's figuring out, is it yoga or stretching that they align with? Some kids like to sketch or to color, and kind of that's their way of getting things out. Sometimes it's journaling and writing about the day. But figuring out what they can build into the bedtime routine that helps them to transition to sleep. One of the big things that I see is that kids basically race to bedtime, right? So they, you know, do homework and video games and electronics, and then they jump in bed. And so once they're in bed, it's the first time all day that they've had any downtime and time to think. And then their brain starts going and everything from the day is coming up. And so the goal would be, you know, building in at least 20, perhaps 30 minutes to transition away from the activities of the day ideally, plugging that phone in far away from the bed. I've seen some families where they have a family rule that all the phones are plugged in the kitchen. I would love it if more families developed that habit, just to be able to say, now I'm really allowed to let go and transition to sleep time. But again, figuring out for each family, what are those like 3 or 4 steps in the process that might be helpful to help decompress from the day. One of those things can be what's referred to as scheduled worry time, which a lot of people have funny reactions to, what you're telling me to worry, right? But the idea is you could set aside a time, either adolescents working on their own or with a parent, to basically process the day, acknowledge anything that they're worrying about, allow themselves to worry, process and work through some of that stress, because oftentimes our propensity is to not think about the things that we're worrying about. And unfortunately, that does not make it disappear. And it often will come out then in physical symptoms or in sleep difficulties. And so building that in each day can again help that transition away from the stress of the day and to help them to feel like they've tolerated it. Interestingly enough, doing this process every day sometimes is really reassuring to families, because, or to adolescents, they'll get there and they'll be like, oh, I actually am not worried. And sometimes just even the awareness of that can be really helpful. I list, again, with pediatrics and adolescents, really focused on how parents can support their kids. There are a number of apps that are helpful for relaxation. I will share more of those at the end. Importantly, medications are not typically recommended as a first-line treatment. They have less long-term sustained effect, and adolescents might then start to sort of rely on those rather than making those long-term changes to their routines and habits. I want to really briefly run through, I share with families regularly, like, what are the processes that impact our sleep? Because I think it helps to just have education about, like, why are you recommending these things, right? And so with adolescents, this is sort of our model of sleep. This homeostatic sleep drive, basically, in simpler terms, just means the longer you go without sleep, the longer you're awake, the more and more our need for sleep builds up. This is important just in thinking through, when is our sleep drive high enough so that we are ready to sleep. Also important because, as you would recognize, if we nap, of course, that's going to be pushed way over, right? The other thing that's important in adolescence is this circadian alerting signal. So sunlight, sort of daily routines, these are all zeitgebers or little cues that impact what our kind of natural circadian clock. And so one of the things we really want to focus on is how do we try to move some of those things earlier if needed, and to align those things so that kids are actually going to bed when their sleep drive is highest. The other thing that happens is that we all sleep in these, by adolescents, typically like 90-minute sleep cycles. And so, we go through the different stages of sleep. The research suggests that we all actually have like these little micro arousals after we come to the end of a sleep cycle, prior to the transition to the next sleep cycle. And so one of the things that happens is that when kids associate, bedtime with rest, relaxation, comfort, what happens is they then have that little micro arousal and they go right back to sleep, roll over, no awareness that they're awake. However, what can happen is that if bed is a place that's stressful, if they are falling asleep with electronics and they're kind of just crashing at bedtime, they may wake up in the middle of the night at the end of one of these cycles and they'll have more difficulty resuming sleep. And so our goal is we really focus on what's that process at bedtime, because that can largely impact sleep maintenance as well. Okay. So the other thing I wanted to talk about is delayed sleep phase. So basically, this means that kids are going to bed about 2 hours later than the socially acceptable or desired bedtime. And so it's estimated anywhere from 5 to 16% of adolescents present with this, I would imagine that that rate is just only increasing with the pandemic. Um, School schedule is a major factor. They actually have shown that in most places in the US, high schools actually start later than middle schools. It does not align with adolescent natural sleep schedule. The way you can distinguish this from insomnia, which is more just those negative associations with their bed, is that if kids were to go to bed at their desired or natural time when they're most sleepy, say midnight or 1 a.m., they fall asleep quickly. So if they go to bed on the weekends or holidays, they sleep well. It's merely the having to kind of shift their schedule where sleep becomes problematic. A lot of this, I think, actually is sort of part of that natural circadian clock in our brain, and there's a genetic component to it. Most adolescents who have delayed sleep will identify as night owls. They say that they're more productive and get more work done in the evening. So that's sort of their preferred sleep schedule. What we often will see is reduced sleep on school nights, sleeping in really, really late on weekends. We can talk a little bit about what happens with puberty and how that shift in the clocks happens. I think it's important to think through one of the things that can happen is that although this is not kids avoiding on purpose or deliberately, one thing that can happen is that once they miss school, they then, this is reinforced because school can be challenging. And so it can develop into school avoidance. If they're learning that my sleep schedule can allow me to get out of school, I may persist in this cycle. So as we discussed, school start times play a large role. There's a lot of advocacy going on within the sleep world to try to advocate for later school start times. In California and other places where they've moved to this for high school students, not only did adolescents get more sleep, grades improved, there were fewer car accidents, better attendance, a lot of factors were influenced by just shifting the schedule to match adolescent needs. So again, when we're thinking through what are sort of these adolescent impacts, a lot of changes happen in adolescence to cause that schedule to shift. And right now, our structures are not aligning with when they would want to sleep. As you can imagine, or as you can sort of see in this diagram, what's often happening is that kids are waking up from school kind of right in the middle of when they are kind of in their deepest sleep. Okay, so what do we do? So we certainly have to work on shifting the sleep schedule. There are sort of two approaches. One is to advance the sleep schedule, and then the other is to actually really delay when kids are going to sleep. We can talk through that in more detail in the upcoming slides. It's a lot of work changing your schedule, and unfortunately, if kids kind of don't follow through, our body really holds on to our circadian clock. And so the strict bedtime, wake times are really the only thing that kind of hold our circadian clock in place. We do use bright light therapy to help in the morning, getting them exposure to sunlight, which can impact things like melatonin. Reducing avoidance of light and screens at nighttime, and then sometimes in conjunction with physicians, we will use melatonin or other sleep-inducing medications. So if we are talking, one approach again is to advance the bedtime, wake time. What we mean by that is to move that slightly earlier. So it may be, this is an example just from one of our sleep textbooks, but it may be that the first night, if they're naturally going to bed around 2 a.m., you then would shift it 15 minutes earlier gradually. I sometimes don't move as fast as every single night. Sometimes I'll give them a few nights at each new time. But what we're doing is we're really shifting that wake time so that by the time they get in bed, they're sleepy. That's the biggest factor, and getting up and getting sunlight in the morning. If that means that they're just like eating breakfast outside or right by the window, that's better than nothing, right? And we lock in once they get to that goal bedtime. We really want to lock in and keep that wake time consistent, because that's the only thing we can definitively control. A process that's much more complicated and challenging, although I've had a lot of kids be successful, is referred to as chronotherapy. The idea behind it is that we actually all naturally operate better on more like a 25-hour clock. And so it's easier to keep ourselves awake sometimes and to put ourselves to bed earlier. And so the idea is actually you're moving your clock progressively forward around the clock, meaning that if you're typically falling asleep around 4:30 a.m., the next night you might keep yourself up till 7:30, and then the next night till 10:30. The goal is that, again, it's a little easier, but you need someone who's really motivated, because at some portion of this, they're actually probably going to be sleeping primarily during the day and awake all night. And again, if they can't follow through, it kind of falls off. So in sum, I just wanted to point out sort of what are the major treatment approaches: consistency, reducing electronics, adding in physical activity during the day makes a huge difference. And just a lot of praise and positive attention around the nighttime behaviors rather than the total quantity of sleep, because that's what they actually can control. Finally, I wanted to just throw out there, there are tons of apps and things that are available now. These are some of the ones that I've seen to be helpful in kids. One thing, this does not apply for adolescents, but I refer a lot of families to the Baby Sleep website, especially with young kids. It's really helpful with evidence-based. It's run by pediatric psychologists with specialty in sleep, and so it's evidence-based information that's free. Again, a number of different apps that are available that I'm happy to talk through more. And I know we're somewhat out of time, so I'm curious to answer questions and or talk about cases that you guys may have.
Well, we got a question up right now, and that's from Mark Meyer. And it says, do you have any recommendations for kids who share a bedroom, particularly younger kids who share with a teen sibling who's staying up late?
Yeah, so I'm curious to hear a little bit more about, I think there are a lot of factors that play into that, right? Is that sometimes the young kids are jealous and want to go to bed later because their sibling is awake. Sometimes the sibling is disrupting them. So I guess what I would say would be, again, focusing as much as we can on that bedtime process. So what I might do is, if the adolescent is staying up much later, I would try to get them out of the room, really focus on the young child's sleep and building in their independence and going to bed, maybe without that sibling present. So working on a calm bedtime routine for them. Then perhaps really praising the adolescent for being quiet when they go into the bedroom, right? Making sure that if they're doing something loud, that they have headphones. But I'm happy to talk through that more. I'm curious to know a little more what your question is.
Yeah, thanks. This is Mark. I think just in general, I deal with a population that has relatively small housing. And so
Yep.
There's many times, sometimes even the parents and the children are sharing a bedroom. So I think just that, I think your idea of like really trying to make the bed for sleeping and having them go out maybe into a living room or something else is what I'm trying to focus on. But there's just a lot of challenges sometimes with that co-sleeping, but also like just sharing a room for multiple members of the family. And I think I often try to just put the little kid and the teen on the same bedtime because I don't really know how else to regulate that. So
no, that is really hard. I agree. I would say if you can, again, focusing more on bedtime, like I often will have, even like kids who are co-sleeping with parents, and if they are really reliant on the parent being there or their sibling, some of the work is just on at bedtime, what that process might be. So again, if the adolescent could either be quiet in their bed and know that they're allowed to, quietly sit up in bed and read or something, or removing them from the bedroom at bedtime and just focusing on the kids' sleep process, and then allowing them to kind of slowly, quietly come in, but it is challenging. Yeah, and with sometimes with parents who are co-sleeping, some of it is even just helping kids to gradually get more confident falling asleep on their own, even if the parent will eventually come in and sleep with them.
Great, thank you very much.
Yeah.
Looks like you were muted.
We can't hear you, Chad. I don't know if you're talking. You're trying. I can see that. I'll go to the chat.
There we go. You would think
Yeah.
you would think the moderator would know how to unmute himself, right? So anyway, so what are your thoughts on over-the-counter light dose of melatonin?
Yeah, it's a really good question. So it can be helpful. You know, the research is somewhat limited in terms of how it's used. Some of the physicians will use it sort of as like a clock. So when kids who have delayed circadian rhythm are going to bed later, they will actually give them a tiny dose of melatonin like several hours before sleep to kind of jumpstart the natural melatonin production.
Mhm.
Yeah, I mean, the research does not suggest that there are large risk factors. So if that can be helpful for kids falling asleep a little bit earlier, the goal is that they're just consistent in using it so that their clock is the same and consistent every day, including on weekends. Ideally with the goal that once they are kind of locked in at that schedule, they can gradually reduce the melatonin use.
That's excellent. Well, I don't see any more questions in the meeting room.
I just have a
And
quick clarifying
yeah, go
question
ahead.
on that. This is Mark again.
Yeah.
So I feel like I often tell parents like use the melatonin when they need it. Like if they're not sleeping well, give them a dose. But what you're saying is they should actually use it consistently, like every night for a certain amount of time. Could you just clarify that?
Yeah, so, and again, I'm not a physician, so turn to my physician colleagues and please ask them that question too. But yeah, the goal is that obviously, you know, melatonin is naturally produced in the brain. And one of the things that can happen is just that we want that melatonin cycle to be consistent daily. So if you can use a small dose daily to basically get them to the point where their sleep-wake schedule is kind of at a good place, that would be ideal. You know, certainly I do know of kids or teens who will use it on occasion if it helps with sleep. I would say that if they you know, rarely have sleep difficulties and that's something that's helpful, it's not necessarily dangerous to do that. But we would love if we could help them to develop relaxation strategies as well so that they're not just relying on the medicine. But yeah, that's a good question. I think it is okay. However, if they are consistently having trouble getting them to a place where they're more consistently going to bed at the same time and waking up is the goal too.
Great, thank you.
Yeah.
Well, this has been a great talk, Dr. Clarke. I really appreciate you getting on with us. We've had some really good questions. And I just like to encourage everyone, if you have more questions for Dr. Clarke, on the screen here, you could see her email address is ahclarke@lurie-children's.org, or you can call into the department at 312-227-6740. And there's Epic In-Basket, Rapid Connect, and of course, I want to remind everybody about our Lurie MD line that you can call in for that as well. And then that will conclude today's, this morning's first session. But we're excited and hope you join us again at 12:30 this afternoon when Dr. Stephen Sheldon is going to talk about agnostic-like breathing. And we have many other great discussions as you see here the rest of the week. So please join us. And like I said, these are recorded. And if you can't, I will be sending a link out. And if you can't join us, you can view the link on our YouTube page. And we encourage you to share that with with your colleagues. So that said, have a great day and we'll see you soon.
Thank you.